Hello, everyone. Today is Sunday, August 23rd, 2020. I'm Jennifer Joe, a practicing ER physician in Boston, one of the early hotspots for COVID-19 affecting the United States. Many of you know me for my work in digital health, telemedicine, and healthcare innovation, which started when I founded MedTech Boston in 2013, the first publication dedicated to covering digital health. I want to thank all the participants who are joining us today for this special live broadcast, where we'll be talking about virtual visits, the promise, the challenge, the future. We're really honored to be joined today by the NextGen Advisor team, Dr. Betty Rabinowitz, Dr. Marty Lustig, and Graham Brown. Individually, they each have deep expertise in American healthcare systems, population health, healthcare IT, and telemedicine. As a group, they have the deepest expertise of anyone I know about how the US has transitioned to virtual visits because of the COVID-19 crisis. Before we get started, I just want to remind the audience of a few points. This is a dynamic and interactive live broadcast. We want you to feel like you're part of the conversation. Many of you are joining us from around the country and have valuable insights to share. So if you're just joining us, we'd like to invite you to introduce yourself in the comments with your name, background, and state or country that you're logging in from. We're going to be taking questions, and we also have a dedicated social moderator who will be fielding them. So please feel free to post your comments and questions, and we'll show them here. For the audience to answer, for our experts to answer, or our social moderator will be answering on the social platform. Please share your experiences. It's been a crazy 5 months, and we're going to get through this together. With that said, please be respectful of all participants and the experts who are joining us today and sharing their expertise. We have 3 physicians and 1 healthcare system experts. When we're not here on our day off, we're working on the front line or supporting frontline workers, taking care of patients. So I want to go ahead and get started with the program. Welcome, everyone. And I'd like to invite the experts to introduce yourselves to our audience.
Thanks, Jen. I'll go first. Betty Rabinowitz. I'm a general internist. I practice primary care internal medicine in Rochester, New York for 25 years as part of the University of Rochester's Center for Primary Care, and actually was fortunate the last 5 years at the university to be the medical director for the Center for Primary Care at a very interesting time. Our first value-based contracts transition to patient-centered medical home. And in that context, became very interested in healthcare data and realized that with all the blood, sweat, and tears we had put into our EHR, there was very little actionable data available for us at the point of care. Managed to create a very rudimentary population health platform within the university. I was fortunate to get some resources to do it. And then eventually the university decided that there was a kernel of goodness in that platform. We used it successfully. And we spun out a company which was called Eagle Dream Health that created a population health, a full-fledged cloud-based population health platform. I was one of the founders and the CEO of the company. So left practice and my leadership position, which were 2 of the biggest decisions I've ever made, and founded this company. We were very fortunate. 2.5 years after we were founded, we were acquired by NextGen Healthcare. And shortly after that, I became NextGen's chief medical officer. So my career certainly in its predominance was as a practicing physician, with a very interesting twist and turn here in these last couple of chapters, and very excited to be now part of the NextGen Advisors team as well as the Chief Medical Officer.
Oh, that's just an incredible story, Betty. Just really impressive that you started your own company. We always talk about diversity in CEOs and getting more women to be CEOs. So huge kudos. Is there, were you afraid or scared, or what made you just said this needs to be done?
So naivete is a fantastic thing. If I knew the risks and the challenges, I probably would have never taken the leap. But I had optimism, a good group of people around me, and took the leap. Obviously, it worked out well, but clearly, it's a very big transition. We live a very protected life in certain ways in medicine from the big world out there. And as a CEO of a startup, some realities became very apparent very quickly. One of them, for example, is when I sent emails as a medical director or a physician, they always got answered. When you start a company, you notice people aren't answering your emails as readily. So it's a humbling experience.
That's an incredible story, which I feel like is a story in and of itself that maybe we'll spend some time on in the future. I'd love to hear from Marty or Graham a little bit about you.
Yeah. So being the non-physician in the group, I've got a different origin story and my path to NextGen. I'm from Canada. And so the first work that I was doing after university was in government, in policy, and worked in a cabinet minister's office in the government of Ontario with a ministry called Community and Social Services, which had all of the long-term care services and then integrated services for people with mental health issues and developmental disorders. I really loved the policy work. And so after moving back to my hometown of Vancouver from Toronto, I got involved in doing administrative work, but in a university system where I was able to do a program in conflict resolution and negotiation. And as happenstance often occurs in people's careers, I bumped into a colleague of mine at an airport who I used to work with, and she happened to be a CEO at that time back in Toronto, and she brought me on to help negotiate the fee service agreements for the Ontario Association of Medical Laboratories with the provincial government. So I ended up getting into doing contract negotiations in healthcare, which was not when I kind of did my policy work in government where I thought I was going to go, so a little circuitous. But it was a really interesting role and I really enjoyed it. And I loved healthcare. It was so multifaceted. There were so many real challenges in healthcare from a systems perspective that kind of weren't getting addressed, or they were, just continuing to get kicked down the road. And ultimately through that role, I got involved in the Ontario Health Informatics Standards Council back in around the end of the last century, in 1999, setting up how the interoperability standards would start working for all of the government bodies and then all of the provider bodies. How could they actually share data in a way? There was no infrastructure, there was no commonality in that approach. I ended up then, after that, doing my master's in public health. And I came down to the United States for that, ended up in Rochester, New York, where Marty and Betty are located. And that work really got me interested in big data, how it applied to populations, and how you could start leveraging information at a new level to really drive care pathways, drive commonality in approach, best practice, and things like that. My work after my master's got into clinical integration. And just after that, the Affordable Care Act was passed in the United States. So I ended up traveling around the US doing consulting work with a large firm based in Los Angeles, and was really helping organizations set up ACOs and learn the rules of MSSP and how are they going to report on this data and who should be participants in their programs. And so I did that for a number of years and continued my management consulting work for the last 15 years or so. Through one of those projects, Betty and I ended up getting to work together. She was with Eagle Dream and leading that company, and I was working with a large client in the Northeast who wanted to bring in a really high level and powerful population health solution. And so we went through quite a long-winded vendor selection process. And Eagle Dream Health was the best platform out there and is now NextGen Population Health. And that client today continues to use that great product. So it was through that interaction that Betty and I got to know each other. And several years down the road, we now get to work together, which is a real joy.
Oh, that's fantastic. You really bring such a diverse background and To say that you enjoy contract negotiation for healthcare systems, that's
It's a little esoteric, yeah.
maybe that's what you're saying. Marty, we'd love to hear a little bit about you.
Thanks. So I think I'll start on the personal side. I come from a healthcare family. In fact, my family, as I think about it, could have been a multi-specialty group practice all by ourselves. We have like 9 physicians and a half dozen other clinical specialists in our family. So I, not surprisingly, became a pediatrician. And I spent my first 17 years at Kaiser Permanente in the Washington, Baltimore area, both practicing pediatrics and over the course of time there, gradually taking on management and leadership roles. In the last several years, I actually was the chief operating officer for the medical group. And at that point, it was 800 doctors, a couple of hundred advanced practice practitioners, and we were under a globally capitated contract for over 500,000 patients. So it was a big operation. I learned an incredible amount. I actually, interestingly, went through the Y2K transition while I was in that role. So we went through all this planning and infrastructure for the disaster that never occurred. And then ironically, a year later, when the anthrax crisis hit, we ended up using all of that infrastructure and planning when I served as the incident commander for that in the Washington, Baltimore area. So that was a really fascinating experience. I learned a lot in that process. After I left Kaiser, I actually came to where I live now outside of Rochester, New York, and I was a CMO for the local hospital system for a couple of years, and then spent the next 13 years as the chief medical officer at the Blue Cross plan in upstate New York. And that's how Betty and I met, when she was at the university and we were sticking our foot as a health plan into the patient-centered medical home and value-based contracts, and she was on the other side of the table from me. And fortunately,
negotiator.
Yeah, right. We realized we were kindred spirits.
Pediatricians, the tough negotiators, that would
Well, fortunately, about a little over a year ago, we ran into each other in the airport, and she called me after I saw her and said, "You know, I've got this idea about how we could might be able to do some interesting stuff together." And so she ended up being the one who came up with this idea of creating a consulting capability so that we could help providers across the country navigate during all these chaotic, difficult times. And so I'm thrilled to be here. The three of us, I think, are having a great time working together, and really hopeful that we can help people.
Well, welcome. It seems like Betty has really assembled an impressive team, an impressive vision, and excited of what you're doing. Marty, the Y2K story, I think most of our viewers who are viewing on their phone have no clue what you're talking about.
Yeah, I thought of that. The gray hair and the bald head and Italian.
I mean, I think it was
they haven't seen.
It was better that like we all prepared for Y2K and then it just didn't happen. It was a little disappointing.
Yeah.
Okay, great. We're here to talk about virtual visits, but I do want to give the audience a little bit of background. You've touched on it. Who are the NextGen Advisors and what you do? NextGen is a well-known electronic medical record company, and how are you different, or how are you related, and what services do you provide?
So maybe I'll take a stab, because a lot of our listeners may be thinking of NextGen as a traditional EHR company, and indeed those are our roots. The company was founded in 1979, so we've been around for a long time. We were leading software and services company, but I like to say that we are not your grandmother's EHR company any longer. We have transformed over the last few years to offer our clients a comprehensive, integrated platform that helps clinicians in the ambulatory space. NextGen focuses singularly on the ambulatory space. We offer our clients the tools, the capabilities, the software, the services to engage their patients, improve the quality of their care, engage and keep their physicians content and productive, and obviously succeed financially, clearly, while interoperating and communicating with a very broad electronic universe, medical universe that's out there. So interoperability, financial stability, engage patients, engage physicians, all take very sophisticated integrated platform, which we now offer, part of which is a highly sophisticated EHR, but only now part of what we do. And obviously with population health tool, virtual visits, many of the patient engagement platform, many of the other tools in the offering. I'll let Graham talk a little bit about the services that the advisors offer.
Yeah. So, I think Betty was in a really fortunate position with the leadership of NextGen to recognize that we had really great implementation capabilities that could support practices to adopt the different technology solutions and really think about how that fit with their workflows. But part of what NextGen hadn't previously been providing was how these new technologies fit with the strategic objectives of the organization. And so the concept around the NextGen Advisors was to bring in that executive level service to really help organizations with their strategy, their governance and organization design, right? How did they make decisions? Who was a stakeholder? Who was at the table? How did their actual operating agreements support their strategic objectives? We've got a group of services around population health management and care coordination. So thinking about how you make real the kinds of programs and services and really turn them into a program model that supports the kind of patients that you're caring for. And then care model design and care model optimization. So helping organizations think about new models of care, team-based care, the roles of different providers. And, in this day and age, how virtual visits really fits in with their care model. How do they change from the kind of practice they were 8 months ago to the kind of practice they are today and make that sustainable, both financially, as Betty was saying, but also from a staffing and operations perspective. So that's a lot of the work that we're focused on with our clients now, is helping them transform in today's very transformational world.
And I would just add that one of the strategic objectives of the company of NextGen Healthcare is to become a trusted advisor to our clients. And the company has made put a lot of focus on becoming that trusted advisor. And one of those actions has been creating a true advisory committee to support further that strategic objective.
Wonderful. That's great to know. I think it's definitely needed. And as healthcare systems go through this transition, it sounds like you guys are perfectly positioned for that. So excited to have you. I wanted to move into talking about virtual visits and your experiences with it. I'm here located in Boston. This is my living room, which is also my kitchen, which is also my dining room. It's one room. So I'm here in Boston, and we were one of the first cities hit by COVID. At least my healthcare system, immediately we heard that and we assessed and we said, hey, we have to flip over all of our outpatient visits to telemedicine visits. I think a lot of healthcare systems around the country face that same, all of a sudden we have a pandemic. We're not quite sure how to respond to it. We want to keep people safe, and we want to make sure that patients get the care they need. So I think that's been happening around the country, but you guys actually have a really interesting perspective on that. I was hoping that you guys could talk more about that, and what I understand is something of a listening tour across the country.
Yeah, well, I'll take that one, Jen. So I think starting with NextGen as a whole, so we have across all of our clients, we support over 100,000 providers, and so when the pandemic hit in March, we very quickly mobilized to help that huge provider base. We got, in the first month, 6,000 of them up and running on a platform for virtual visits. And since March, we've enabled over 650,000 virtual visits already. So it's really, the transformation that was required, we've watched it take place and supported it taking place for our clients. At the same time, the advisors were just getting started and getting organized when the pandemic hit. And we decided that the best use of our time was to reach out to leadership across our client base to learn from them what were the challenges they were facing, how were they responding, begin to understand best practices and start sharing them with each other and with others. So we started this listening tour in late March. We met with about 25 thought leaders across more than 25 thought leaders across about 25 organizations. They represent about over 5,000 providers, and they were really geographically distributed all across the country and across different specialties. We're now entering our third round of conversations with those folks. So we not only were interested in what was happening when the pandemic struck, but how things have evolved and how their thinking has evolved about the future as they go through this process.
It was really, I'll just add on to what Marty's saying there. It was a really fun experience fun and challenging at the same time, because you're watching the pandemic unfold, which was such a disturbing thing. And I think each of us with either physician or kind of public health backgrounds had this anticipation of how bad it could get. And indeed, it started getting worse. And, New York and Boston were being particularly affected. And then that started spreading around the country. So when we first started these conversations in March, there was folks we were speaking with in some communities of the country that, really thought, well, it may or may not come here. This may or may not be an issue for us. And ultimately, it's affected every community in the US. And we've seen that really evolve over time. So some of our early conversations with some folks were in parts of the country that were very strongly impacted, up the Hudson Valley, for example, outside of New York. And then speaking with, 2 months later with people in Texas who were going through a different wave of it. It's been really, really interesting, heartening in many ways, but also disheartening in others to see how impactful this pandemic has been on ambulatory practice.
Sure, absolutely. It's been difficult, I think, for everyone. You guys have been on the front line talking to providers and really supporting them and rolling out solutions to provide care during this. So very excited that you're here to share your expertise, and wanted to just dive into learning a little bit more about that. And talking to the clinicians that I know, the challenges early on were numerous. There's still many challenges. The three biggest things that I heard were technology, payments, and clinician adoption. So I was wondering if we could talk. You guys are nodding your head.
Those sound like familiar themes. Yeah.
Those are the buckets, and all of the concerns and challenges that people have brought forward, and we've heard about, kind of fit into one of those three buckets. I'd like to touch on the technology bucket first. It's unprecedented how quickly a technology was adopted. It took us years to implement EHRs across ambulatory medicine. It literally took years. Within a matter of weeks, there was an enormous uptick in the use of a specific technology, which fortunately, NextGen acquired a virtual visit company in November, anticipating that virtual visits would become an important factor in the future. Little did we know that by February and March, we suddenly were rushing to implement clients in droves on this software to allow them their response to the pandemic. But there have been challenges. The challenges have had to do with bandwidth. Some of our clients who serve served populations, federally qualified populations, clinics, health centers who serve underserved groups, folks don't have the right hardware. The bandwidth that they have isn't able to support these visits. So fortunately, regulatory allowed converting some of these visits and paying for them with telephonic visits. But that was one of the challenges. If the software, we're fortunate that the platform we acquired that is now NextGen Healthcare Virtual Visits integrates into the clinician's workflow. If the technology wasn't able to do that, it created a very disparate workflow for physicians that were going into the EHR on one hand and their virtual platform on another. What was important is that the technology is usable, that patients, elderly patients, less savvy patients don't need to create a password or log on or download a application, because we found that technologies that folks were adopting that required that weren't easily utilized by patients. So it was an advantage to us that those weren't necessary. It was not simple to get a new technology implemented in a very short time. But it was great to see the resilience that the group showed. I'll pass it to Marty.
Thanks, Betty. Well, timing is everything.
Yes.
So I'd like to talk a little bit about the payment side of it. And all these issues are so interrelated. I think one of the things that made it possible for this very rapid adoption was the very rapid movement of the government regulators at both the federal and state level, as well as the commercial payers, to allow for both for payment for virtual visits, but all in payment parity in most cases, but also to loosen the regulations around HIPAA so that people could get things implemented in the short run. From a payment perspective, though, I think there's a challenge issue here, which is we heard it from all of the clients, literally all of the clients we've talked to. On the one hand, they all say, this has been a watershed event. We're not going back. Virtual visits are here to stay. And then the next comment, or at the same time, that is if the payers continue to pay for it. Nobody has a crystal ball. We don't know for sure what's going to happen. There's been a lot of signals from both the government and the commercial payers that there's some intent to continue payment going forward. I doubt that the HIPAA rule relaxation will continue, but I do think that there, even in the most hopeful scenario where the payers and the government sort of keep the payment, sustainable payment for virtual visits in place, there's another market force that providers need to think about long term, and that is that even before the pandemic, there were several national telemedicine services out there that were providing at least generic services at a very low cost, probably about half of what a comparable face-to-face visit, if not less, would be. And in the long run, if those providers are able to continue to provide services at that low of a cost, and knowing that high deductible health plans are out there and more prevalent than ever, there's going to be pressure to find ways to deliver these services that are at least somewhat competitive with them. And I think it makes it doubly important for providers to think about not what they've been able to do in the short run as a patchwork solution to get virtual visits up and running, but long run, they really need a platform and a workflow process that drives for efficiency in delivering these services so that they can provide the most value, but do it in a really efficient way so that they can be sustainable and competitive in the long term. So I'm really excited about those possibilities and hope that we can help folks with that.
The clinical adoption piece has for some providers really been a challenge. I think, you noted, Jen, that for some it was a quick and easy transition into, just kind of, I wanted to do this, or some providers had already started doing virtual visits before the pandemic occurred and had a sense of the technology. But that huge uptick, as Betty was referencing, really did require a lot of systemization that wasn't in place, or standardization. And it was fascinating to speak with folks from around the country who had quite different experiences. Some older physicians late in their career loved the technology, were happy to work from home, had a much more flexible schedule. And they were able to, once they got their handle around how this is going to work, they were able to be much more productive and see more patients than they had in their face-to-face encounter world. Similarly, I think we heard from other providers that the clinical adoption was as much constrained by the patient side of the equation. So the provider might have had, a handle around the tools, and they may have been already working with their medical assistants or registration staff to queue patients up, to manage how the kind of the flow of the visit was going to work. They really put the thought and the effort into the workflow. But where that didn't occur, and you had the provider kind of working independently, trying to manage the logistics side of it, and then the patient interaction, and then the documentation element, it became much more fragmented and haphazard. And so some clinic environments really, kind of let the doctors figure it out the way they wanted to, best of luck, here's the tools, we hope you can take it on. And so had less success. I think they learned, after a month or two, that they really needed some coaching from clinicians that had figured it out, that had, put in place a nice, easy workflow, and were really able to kind of take best advantage of a virtual visit approach. And ultimately, we're able to coach and mentor others to be just as successful. But that curve was different for many different providers.
Absolutely. That's such great points. And I do want to just underscore that I think I'm friends with a lot of digital health advocates who have been excited about this for a long time. And when COVID hit, they were asked to suddenly teach all of their other colleagues how they've been doing telemedicine. And they were surprised. And I think the healthcare system was also surprised that you have to have a program in place, you have to have some structure, and you have to educate the clinicians on how to use the software. And that's huge because clinicians are sometimes very stubborn, and they're just like, no, we're not going to do it. So you have to.
Never met a doctor like that.
And, we have to give credit to the fact that we are interpersonal relationships are so important. What happens in the exam room is sacred. There is a special connection. There is a special connection when you have touched a patient, examined the patient. It's really difficult. I hear people underestimating the shift that has occurred. I think the promise of what has happened is that you can create a hybrid model where some visits can occur in person, and we will have to figure out which are the appropriate visits to occur with this modality. And other visits, when the epidemic has subsided, will be able to return to in-person, and certain patients will continue to benefit at certain times in their health journey from in-person visits, and at other times. I think creating unrealistic expectations that the entire healthcare system is going to go virtual is a recipe for heartbreak, because in reality, what we're hearing from our clients, we did a survey of participants, over 100 participants in a conference that we ran, and the majority of them felt that a number between 15 and 25% of visits post-pandemic will continue to be virtual. And sometimes people kind of are disappointed by that number. Think of it. Prior to the pandemic, there were almost no visits being done virtually. If we can stabilize at 15 to 25% of visits with appropriate patients at appropriate times virtually, it is an incredible win for health information technology, practice transformation, cost effectiveness, convenience, patient engagement, all benefit from that tremendously.
So I have comment, but it's a little bit in parallel to what's been discussed, but I think it's important to acknowledge one of the things that we heard as we talked to folks across the country is that this adoption and implementation for primary care, and especially for behavioral health, has gone pretty smoothly. In fact, from a lot of behavioral health providers, they see it as a huge step forward. They actually, many of them are more productive today with virtual visits than they ever were with face-to-face. And they're finding that they can provide effective services, and it may become a predominant part of the way they deliver care. Mm-hmm. On the other hand, some of the subspecialists, whether they're particularly the procedural ones, but even some of the cognitive specialists that have more specific issues or that are a mixture of procedures, it's been more challenging. What's heartening and interesting is even with like orthopedic surgeons who you think of as purely procedural, they actually jumped into this space and started figuring out how to do pre-op planning and post-op evaluations and make sure that patients were being managed, the non-surgical patients were being managed, and doing follow-ups in chronic care. So everyone that we spoke to has figured out ways to use it, but I didn't want to miss the chance to say that it has been more challenging for a lot of the subspecialists.
Mm-hmm.
So I think that's, go ahead. No, go ahead, go.
I think overall, one of the things we all three of us came away with from these conversations across the country was how resilient, inventive, hardy, motivated, and dedicated these clinical groups were to making it work, figuring it out. I saw a comment come past. Somebody said when the asteroid hit Earth, COVID, and I agree with that person. But I have so much respect, and I have always had respect, but it was so wonderful to watch the selfless dedication and ingenuity that people applied to getting this figured out. And one wonders if it's there when an asteroid hits, how do we sustain it? How do we keep this sense of adventure and I'm willing to try it, and I've never done this before, but I'm cool with it, versus some of the struggles we had around dragging the paper charts out of the clutch of physicians who felt that nothing would ever substitute their paper notes.
So I think those are all good points, and yes, I remember the transition from paper to the EHR, and there wasn't just one paper chart, Betty. There was like 4 or 5 that you had to like go to the patient's bedside, see the vitals, go to the nursing station, see what happened overnight, go to the pharmacy station, see what medicines they got, and then like go to the doctor station and like see what the doctors wrote. It was like this whole collection. Like I'd have to go check 4 paper charts before seeing one patient. Anyway, that's a
and that's a topic for another conversation.
But yeah, no, I do think that's important to underscore, which is the creativity and ingenuity of clinicians and healthcare systems in trying to deliver care and making sure it's done. And they worked really hard, and you guys have supported them. Mm-hmm. So I think we've talked about a lot of really good themes. And I want to just talk about, when we talk about the challenges, sometimes we get lost. You guys, I think, have already highlighted a couple of really good points, but I was wondering if you could share some stories of unusual delight that you heard from across the country of where it worked and it was just beautiful. Maybe the clinician said that, maybe the patient said that.
I see Marty switch modalities.
We had a brown out here. It's a hot day. It's probably every.
Yeah, I'll get started. One of the best stories we heard was an OB-GYN group in the New Jersey area that adopted our virtual visit platform very, very quickly. So we helped them. They realized they had all of these women expecting. You can't stop a pregnancy for a pandemic. So they implemented virtual care, and they did two things that were really fantastic to learn about. One was they, when women continued to come in for their ultrasounds, they postponed doing physical exam components that they would have done in their routine OB visits to the time that women came in for the test. And either a nurse practitioner or if someone else who had the skill was available, when they had the ultrasound, those pieces that required laying on of hands was done in that at that time. But the other thing that they did was quickly explored getting a mobile Doppler equipment, as well as connected blood pressure cuffs, so that women in high-risk pregnancies or women who needed additional follow-up could do it independently at home, connect them to a virtual visit, and convey this information. Unfortunately, not yet connected and integrated, but at least the information was there. So it was lightning speed that this group had all of the ongoing care of their pregnant patients completely figured out virtually and effectively, and created a sense of safety and security for the expecting mothers. It was a terrific achievement.
You know, Jen, I've got a story that comes to mind. There's a federally qualified health center out in California that we work with that serves indigent population, a lot of farm workers, and they're in a rural community, really poor, bandwidth availability. A lot of these folks don't have smartphones. They don't have the technology to, do a virtual visit on their device. And so what this clinic did was, as they were setting up their drive-through testing and drive-through triage in their parking lot and registration, folks would come up in their cars. And if they would send a nurse out to evaluate the patient. What are you here for? And, what are you sick? And understanding that. But then if they could do a visit virtually, they would provide the person in the car with an iPad and have them pull over to a part of the parking lot. The iPad's connected to Wi-Fi in the clinic. They can do the full virtual visit right there, hand it back to the registration person who can wipe the iPad down and get it ready for the next person. So they were really able to, not give the people an iPad, but bring them in still in a very safe way, get them connected in a virtual visit, have it all go just according to plan, and do it in a really time-effective way. They adapted this approach really quickly. I mean, they were doing this back in April. So that was really interesting to see how quick and innovative they were to recognize this is what our patients need. If we're going to deliver this new modality and we're going to continue to safely see people, particularly those that need care, how are we going to do it, in an innovative way? And they solved that pretty fast.
So this is the first time you're sharing that story with me. That is a profoundly innovative story that solves a lot of problems. That's incredible. I think it's more important now because there's a big concern that access to healthcare and people who don't have the access to the technology, how are they going to continue to get access to healthcare? And that disparity is just going to get greater and greater, and that's the biggest concern. This is the first time I've heard you share the story, which I think is actually an incredible solution that I can't think of why I haven't thought about that before. We have iPads just lying around in the ER that I practice, and I have no idea why they're there.
Yeah.
I know. I'm supposed to give them to a patient. Well, they don't drive. I don't have a drive-through, but I'm going to try that. That's
it was a really neat approach.
Think about once the pandemic subsides, having a private room in libraries where patients who don't have access to Wi-Fi can go and secure book some technology and Wi-Fi connection to visit with their physician from their neighborhood instead of driving or riding on the bus halfway across town.
But something you may not have heard of, Jennifer, because you're too young, but telephone booths that have iPads in them that are automatically connected to healthcare providers.
So
Right.
when I come out, do I become Superman? No.
Yeah, right.
No, okay, sorry, Marty, tell your story.
No, I do think that story that Graham told is an important one. I wanted to tell, being a pediatrician, a pediatric story. One of the docs that we spoke with, again, she was in Southern California, told us about this, where she was concerned, as many of us in pediatrics were, that it might be difficult to care for infants and toddlers wearing a face mask, because they're unlike even more than older people, they're very sensitive to the eyes, nose, and mouth facial expressions in terms of feeling comfortable in a human interaction. And what she found was that with virtual visits, she could introduce them to the mask. So she could start off without her mask on and then add the mask. And combining that with educating the parents and getting the parents to wear masks around the kids, that when the kids did have to come into the office for whatever reason, it actually worked fine. And they adapted, they had already become accustomed to her wearing a mask. And so it was actually really interesting that, combined with overcoming the mask problem, she also found that seeing the parents with their kids in their house actually enhanced her relationships with them, to get a sense of what the living environment was like and the interactions in the house. As the mother or father were being distracted by the other kid, you got much more of a sense than you do in sort of the artificial space of an exam room. So she actually was able to overcome the challenges and actually sees it as an enhancement to her overall practice now that she's got virtual visits integrated with her whole practice.
Yeah, no, I really love that story. It reminds me, my dad's a family practice physician in rural Mississippi. I grew up in a tiny town of less than 10,000 people in rural Mississippi. And I think that brings us back to, everyone talks about when doctors were like the family doctor and you ran into them at the grocery store, the bank. It really brings back that tighter relationship. And I think that's what a lot of patients have craved and missed. So I think that's interesting that you've highlighted that virtual visits have that capability.
And I think that, again, for another conversation, is the conversations we've had with people around what's happened to their waiting rooms, how they have been completely changed in their purpose and their use. Parking lots have become much more important than waiting rooms. We have shifted all of the check-in, the pre-visit activities are now part of a patient engagement platform that allows people to register, pre-register, pre-qualify for the visit. I have a feeling there are going to be thousands and thousands and thousands of square feet of office space that are now waiting rooms that will need to be repurposed. For example, some of the offices that have common workstations for physicians where you could sit quietly and do your notes now need space for physicians to be privately having visits, telehealth and virtual visits with patients without people walking behind them in the background. So there is a shift in the practice of the future that is happening in the physical space, the workflows, the staffing requirements, what medical assistants do, what they used to do, how they can be utilized differently. That's a whole nother conversation. That's an offshoot of this telemedicine virtual visit transformation.
Yeah, no, I totally agree. And I just love to underscore how you can use this to actually close the gap in access to healthcare if done right. And we need to be attentive to that. And it could be that we repurpose libraries that are in small towns and they could be telemedicine booths. Absolutely. And they get access to primary care physicians, but not only primary care physicians, they get access to specialists that have been very hard for them to access, like a stroke specialist or a cancer specialist.
Yeah.
Sky's the limit.
Sky's the limit.
Yeah, I think this is another whole topic, but one of the things that we saw in the midst of the pandemic was a fair amount of variability in terms of the clinical criteria for appropriateness for virtual visit. In many cases, it was left to the individual practicing provider to say, I think I can give people what they need based on, a virtual visit, or they would try it as a virtual visit. And then if it didn't work, they would bring the patients in. But really becoming more sophisticated and evidence-based, and particularly when you start getting into specialties. I know, here in Rochester, at the university, there was a neurologist who did a big study on using virtual visits, especially for rural populations who had movement disorders. People, for example, with Parkinson's disease, and he was able to demonstrate dramatically improved outcome, wonderful patient satisfaction, and certainly, very cost effective both from the patient's point of view and from the provider's point of view. So I think those kinds of studies that delve down into the different specialties and find the best way to provide services, there's a lot of work to be done in that space.
Absolutely. I totally agree. So I think we've heard a lot from our experts. I want to invite the audience to remember to post their questions, and then we're going to move into some questions. So I'm trying to find a great question for our panelists. I don't know how much experience do our experts have with providing telemedicine to ambulatory practices in more rural settings. Graham, it seems like you guys have some experience there. Okay, sure. If you guys can talk about it, I will share my dad's question. Okay, Dad. You
is unique to Mississippi.
So my dad has joined us. He's a rural physician. He hasn't loaded his photo outside of the Jackson area, but can you speak more to supporting ambulatory care practices, specifically in rural areas, which, Graham, you've already mentioned? There are farmers, there are field workers, there are people who just don't have access to internet. My dad has very slow access to internet. How do you support telemedicine and virtual visits in those scenarios?
Well, I don't know that the model is necessarily particularly different from how you would do it in a different environment, in a more urban environment. Interestingly, from the payment side, it was the rural communities across America that were first eligible for virtual visits, right? Because you couldn't extend the specialist services into populations where those providers didn't reside. And so with COVID coming about and, the ability and the need to really serve people in a new modality, I think the rural environments need to recognize the challenges around bandwidth that we spoke about earlier, and around being able to do things still in a private way. Rural communities tend to have, small populations. Everyone knows everyone. So I think another aspect of thinking about providing virtual visits in a rural environment is how do you do that in a private way if folks need to go to a common place, as we were describing before, right? The parking lot with an iPad, or some other common place like a library, as Betty was suggesting, might be a model of the future. How do you do that in a way that still retains that privacy so that you're not, just de facto then sharing protected health information because people don't have the right environment to do it in? But I think bandwidth certainly is one of the major challenges that sits out there. And so being able to provide the right access to the technology is probably key to some of those.
An interesting twist on that is that prior to the pandemic, as folks probably know, the rules around reimbursement for telemedicine often required that the patient actually be physically in a doctor's office in order to receive those services. That is, as inconvenient as that seems, it is a way to overcome the bandwidth issue as long as the physician's office in those rural areas have the infrastructure themselves. At least that provides a secure connection. Obviously, ideally, it would be nice to have broadband availability as part of the infrastructure, particularly for rural areas, for the community as a whole, not just for healthcare where they could tap into it.
let's get to, I have some thoughts, but I'll communicate with your dad offline.
Okay, great. So I wasn't necessarily going to show this question, but we got the go ahead from the production crew that John Nasta, thank you for joining us. You're always a big advocate of telehealth. The production crew approved that we're going to ask the question, who is the bigger obstacle to telemedicine, the physician or the patient? Oh, that's such a controversial kind of pokey question, John Nasta.
So I like John's previous question. He asked a question about waiting rooms as learning rooms. So
I love the waiting rooms as learning rooms.
Yes.
Yeah, I agree.
John, great questions. I'll take a quick stab at the waiting room and learning room. I think that obviously people have been very creative with waiting rooms. I think the pandemic and the way people congregate in waiting rooms has been the challenge.
Absolutely.
So when it's safe to recongregate, I agree with you, those spaces can be used very creatively. At the moment, probably not a very good idea unless the physical space has changed. To your questions about barriers, I'm going to say here, I usually like taking a very clear side, and it's usually the patient's side. But I'm going to say, I'm going to put a blue helmet on and say I'm with the United Nations on this one. I think that there are physician components, plenty of them, and I think there are patient components. I think the referee is the payment system, and that we absolutely have to have reimbursement, maintain motivation, support for this transition, because physicians' concerns are completely legitimate. They are going to have to overcome the I've always did it this way and not another way. And patients as well are going to have to figure out what's appropriate. And when they're asked actually to physically come in because it's more appropriate, they need to be accepting of that. I actually see the problem with patients as being reluctant to engage in a hybrid model now that we've created a bit of a monster of convenience. So I think there's plenty to go around. So I'm going to take the middle of the line on this one.
So,
okay, so this is John. Marty, sorry.
Yeah. Okay. I was going to hop in and say, I actually think that in some ways, although there are obviously a lot of differences, in some ways it's almost an artificial distinction, because those same doctors who have barriers, if they were a patient, their barriers would be the same as they are as a physician. Mm-hmm. And the patient's barriers, if they were providers, they would be resisting it for the same reasons. And what we've found overwhelmingly is whichever seat you're in, once you have a successful experience and you get comfortable with it, which actually doesn't take very long, then it actually is not a barrier on either side. You know, the advantage of the provider is that they do, if once they do it, they're doing it all day long, so they'll remember. The patient, if they have very infrequent contact, may have to relearn it every time. So on the patient side, it's going to have to be easy and similar to all the other stuff they do.
Mm-hmm. Great points, and you guys handle these questions very well. We're close to time, so I do want to just hear big themes or closing remarks from the experts, and maybe also sharing a little bit of what's getting you through COVID life.
I'll go quickly first. We just adopted a puppy last week. She's a year old. She's a rescue. That is helping us get through COVID. Crazy idea it was, but it's fabulous. The second thing is I've never been more proud to be a physician than in this time. And I've never been more proud to be part of a health information technology company that is truly doing everything that they can to support our clients through this tough period. So it's been a terrible time and an amazing time at the same time.
Mm-hmm. As somebody who used to travel every single week of the year, going to clients around the United States for a long, long time, I got to say that the bright side of the COVID pandemic is that I know where my clothes are. I don't have to buy a toothbrush every week because I forgot it somewhere. I'm not earning the frequent flyer miles, but that's okay. It's nice to have kind of a sense of normalcy and stability back, and a family life and a home environment. So that's certainly, I love to cook. I get to cook all the time. That's a real treat. And I think, to echo what Betty said, we're so privileged to be able to connect with providers who are really doing excellent frontline work and to hear their stories. And that's really energizing to know that, we are in a very great position to be able to support them with some advice and guidance and the tools that they need to do their work. And we get to see and hear their stories in return. So that's a real joy.
So I'll make it short and sweet, because I would say that pretty much the same things that Betty and Graham just said. All I'll say is it's a great time to be a natural introvert.
You don't seem like an introvert on this broadcast.
Thank you. I'll take that as a compliment. But
Okay, well, thank you to everyone. This has been an incredible discussion. A big thank you to the NextGen Advisors for sharing their expertise with us today, and a bigger thank you to the participants who joined and who are contributing to delivering the best healthcare despite the challenges of COVID. This live talk show has been recorded. Please feel free to share with friends and colleagues. If you have questions for the NextGen Advisors, please feel free to contact them through the NextGen website, nextgen.com, or the email that we've posted on the screen. If you enjoyed the show, the NextGen Advisors have a blog and a podcast that you can follow on their websites. Have a good Sunday, and thank you for joining us. We're in this together.